The first transplant was done in 1962. There are 58 organ procurement organizations. Page 1051 in your textbook talks about the plan of care for somebody who's getting transplant. The critical pathway you need to follow for the organ donors on page 1053 to 1055. 43% of donations are from living donors. In 2008, there were 14,202 transplants in this country. 6,218 were from living donors. 7,984 were from deceased donors or cadavers. Just as a reminder, because you may not remember your normal immune system quite as well as you want to, your lymphocytes are your major cells of immunity. The B cells produce immunoglobulins. They mark the cells for destruction. Your T cells are responsible for cell-mediated immunity, and there's a figure on page 1058 that talks about them. You have your cytotoxic T cells that kill invading cells. You have your helper T cells that increase the immune reaction by stimulating B cells and activating cytotoxic T cells, and by stimulating your natural killer cells and your macrophages. Your phagocytes function you'll find in a box on page 1059. B cells, T cells, natural killer cells all communicate using interleukins, and your immunoglobulins form your antibodies, and you can find a figure about that on page 1057. Graft rejection can be hyperacute, acute, or chronic. Hyperacute occurs within hours. We prevent this by doing pre-transplant testing for just about everything except the heart. Acute occurs within weeks to months after the transplant, and chronic occurs years later. Treatment to prevent this, they'll be on immunosuppressants to help to control the helper and cytotoxic T cells. There's a table for the meds that are used on page 1060. Steroids, mainstay. Cyclosporins decrease your interleukins and your T cell function. The tacrolines are newer. They have fewer side effects, do about the same thing as the cyclosporins. Azanthropine, or Imuran, decreases purine synthesis. So your side effect is a decrease in your white blood cell count. So you have to keep a close count of your white blood cells. Mycophenolate has very few side effects. Those are nausea, vomiting, and diarrhea, so that works fairly well. Your sirolimus is given for acute rejection prophylaxis. The diet should be one that is low in sodium, low fat, and low cholesterol. You need to make sure that they don't have hypertension. Postoperative care, you check their blood sugar, their blood pressure, and 24-hour urine for amylase levels. Heart transplant, the selection criteria is that they can only survive for 1 year without a transplant, and they have to be under the age of 65. The first one was done in 1967, and he lived for 18 days. There's a box on page 1063 for the contraindications, and a picture on 1064 for what it actually looks like. The meds that are used for 48 hours post-op, you've got isoprel to support the heart rate and dopamine to support the blood pressure, because these patients will have two P waves, because you'll have two atria, but the actual innervation of the heart muscle is not there because you've cut the nerves. Rejection will occur within the first 3 to 6 months, and you'll notice this because they'll develop hypotension. So you may need to do a biopsy to assess rejection status. They may require these forever, and there's a box on 1065 that talks about it. You need to treat the rejection with IV Solumadrol. They're immunosuppressed after surgery, so that means they're at increased risk for infection. And for them, a significant temperature is a temperature of 100.4 Fahrenheit or 38 degrees centigrade. Major threat is your CMV virus, your cytomegalovirus, and your herpes virus, so they have to be very cautious. They have chronic immunosuppression that can cause significant morbidity, such as osteoporosis, obesity, and avascular necrosis of the joints. That occurs particularly with your Solumadrol or your steroids. You'll have an increased risk of coronary artery disease, an increased risk of malignancy and infection. 85% of these patients will survive 1 year. Nursing diagnoses are on page 1064. The heart and lung transplant, the first one was done in 1981, and they survived 5 years, so that's good. An indication for this, they're listed in a box on 1067, but one of the primary ones is that they will only live for 15 months to 2 years without one. They are contraindicated. Contraindications are listed on the same page. Oftentimes this is done as a domino procedure. In other words, you donate the native heart, because your native heart may be okay, it's your lungs that are the problem, to another recipient, and then you get the heart and lung of somebody new. There's a surgical procedure figure on page 1067, but you need to observe them very closely for bleeding. If they have normal clotting and chest tube drainage of 100 to 200 milliliters an hour for 3 hours, they're actively bleeding and you need to call the physician and they need to have something cauterized. They are at risk for acute lung injury. You need to do very gentle suctioning with them. They'll be on a ventilator for 12 to 48 hours with about 5 centimeters of PEEP. And your nursing diagnoses are on page 1068. They'll also receive some isoprel and dopamine to maintain that heart rate and blood pressure. Alprostadil will be given for pulmonary vasodilatation. Nipride for vasodilatation. You will avoid steroids for 2 weeks so that this new heart and lung can heal appropriately. They are at risk for infection and rejection, so they will get pulses of corticosteroids, like 1 gram IV push every day for 3 days. They're going to increase the cyclosporin, and they'll do pulmonary function tests to assess their function. About 61.8% of these patients survive. They may also develop obliterative bronchiolitis, and if they do so, they require another transplant. The single lung transplant survival rate is about 76%. The care is basically the same. The double lung transplant is 78.3% survival. Your nursing diagnoses are on page 1071. Liver transplant. Selection criteria are on page 1072, but some of them are if they're a child with biliary atresia or they're an adult with hepatitis C. 1967 was the first one that was done, and they lived 1 year. In 1983, we were doing less than 200 a year. In 1999, we're doing more than 4,700 a year, and your 1-year survival rate is at least 70%. Contraindications are on page 1073. Your preoperative risks, hepatic encephalopathy, coagulopathy, portal hypertension, severe fluid and electrolyte imbalance, cardiac compromise, and renal deterioration. These patients are usually in the hospital for 31 days. Their surgery lasts 10 to 12 hours, and the surgical procedures that are done are listed on page 1076. Your nursing diagnoses are on page 1077, as well as the complications are on 1077. Your pre-transplant histories questions are on page 1073, and the testing, pre-op testing, are on page 1074. A kidney transplant, keep in mind that a kidney can survive up to 72 hours outside the body. The first one of these was done in 1954. There's a box on page 1080 for your contraindications. Your nursing diagnoses are on page 1081, and 1082 has your rejection criteria. These patients are in the hospital for 5 to 7 days. The cost of their medications, for which they will be on for life, are about $1,200 a month, and the government will help for the first 30 months only. So this is a problem for them. $1,200 a month is a lot of money. Pancreas transplant, the figures are on page 1084. We have an 82% survival, 92% survival if it's done with the kidney also. And we also have some islet cell transplantation that's being done that's investigational still. There are studies going on, and I know of somebody who had an islet cell transplant who had been type 1 diabetic for all of her life that she can remember, and she's 36, and for the first time ever, she does not take insulin. She's still checking her blood sugar because that is required for the study that she is on. Nursing diagnoses for a pancreatic transplant are on page 1085. So this could actually take care of type 1 diabetes. Type 2 diabetes, no. But type 1, yes.